Good evening, everyone, and welcome to part 2 of the Black Maternal Health Project series. Thank you for joining us. This evening's presentation is titled Pre-Screening and Managing Chronic Conditions. My name is Kai Perry, and I am the Program Manager and Advisor on the Black Maternal Health Project. In a few moments, you will see an option display to partake in a poll for which you will be entered for the chance to win a $75 gift card after completion. I'll allow some time for you all to answer the questions and we will reconvene. Now, I would like to introduce you to the Black Maternal Health Chair, Janelle Lawson. Janelle, come off mute.
Thank you, Kai. Hi, good evening, everyone. My name is Janelle Lawson, and I am the chair of the Black Maternal Health Project and the Deputy Director of Community Action Agency of New Haven. If this is your first time here with us, thank you for tuning in. And if you are returning, thank you for your support. The Black Maternal Health Project is a collaboration of 4 nonprofit organizations in the greater New Haven, which share a united mission to spotlight the numerous obstacles Black and Brown women face in healthcare today. The organizations are the Community Action Agency of New Haven, the New Haven chapter of the Links Incorporated, the National Coalition of 100 Black Women Metropolitan Chapter, and New Haven Healthy Start. Now I will hand it over to one of the co-chairs, Tony Harp. Tony?
Thank you so much. Hi, my name is Tony Harp. I'm the president of the New Haven, Connecticut chapter of the Links Incorporated. For 52 years, the New Haven chapter has served the greater New Haven community through 5 service areas: the arts, services to youth, national and international policies and programs, as well as health and human services. Our chapter is so delighted to be a partner with the Black Maternal Health Collaborative. Its mission aligns with our organization's missions. And the mission for the Black Maternal Health Project is dedicated to empowering Black and Brown women to effectively navigate the healthcare system, to eliminate disparities and maternal mortality rates by achieving positive health outcomes through a comprehensive approach that includes advocacy, community engagement, and education. We call that ACE, and you'll learn more about that from the other co-chair, Lorraine Gibbons. She is the president of the National Coalition of 100 Black Women New Haven Metropolitan Chapter.
Thank you, Tony, for that warm introduction. My name is Lorraine Gibbons, as you heard, and I'm the president of the National Coalition of 100 Black Women, the New Haven Metropolitan Chapter, where our mission is to advocate on behalf of Black women and girls to promote leadership development in the areas of health, education, and economic empowerment. And so this Black Maternal Health Project fits so nicely within our mission. And so just to talk to you a little bit about the vision of the Black Maternal Health Project, where we strive to create an equitable healthcare environment where every woman can access the resources and support necessary for a healthy pregnancy and childbirth experience. And we're doing that through 3 platforms, which you heard is ACE, which stands for Advocacy, Community Engagement, and Education. And so tonight, you'll hear more about the educational aspect of what we're trying to accomplish tonight with regards to us creating more of a healthcare, equitable healthcare environment. And so now I'll turn this over to Kai. Kai?
Thank you, Lorraine.
You're welcome.
Before I introduce you to the Black Maternal Health Advisory Board, please take note of the Q&A option below where we ask that you add all of your questions this evening. Additionally, there is a closed caption option for those who may need it. Meet our advisors. Janelle M. Lawson, Chair, Tony Harp, Co-Chair, Lorraine Gibbons, Co-Chair, Dr. Cynthia McCraven, Medical Advisor, Miriam James, Strategic Planning Advisor, Sonia Brevard, Health Committee Chair, Dr. Gretchen Vaughn, Mental Health Advisor, Natasha Ray, Advisor, Peyton Owens, Project Manager and Marketing Advisor, Maritza Bond, Public Health Advisor, Stacy Fields, Health Committee Advisor, and myself, Kai Perry, Project Manager and Advisor, and Dr. Sharon Jones McCann, Advisor. Now I introduce you to your moderator for this evening. Dr. Sharon Jones McCann, who was raised in New Haven, attended New Haven Public Schools, graduated from James Hillhouse High. Currently, she works for the town of Hamden in the Office of Community Services, which is a department in the Keith Community Center. She oversees programs that include Hamden Food Bank, Camp Scholarship Program, Fuel and Energy Assistance, Relocation Services, and the Rental Utility Assistance Program. Dr. Jones McCann has earned degrees and certificates from Springfield College, Fordham University, and Gateway Community College, culminating with her earning her Doctor of Social Work in May 2021 from Southern Connecticut State University. Dr. Jones McCann is licensed by the state of Connecticut's Department of Public Health as a master level social worker. Dr. Jones McCann is also licensed by the National Council for Mental Health Well-Being as both an adult and youth mental health first aid instructor. Sharon has over 40 years of human services, effectively working with underserved high-risk populations, collaborating with various state of Connecticut agencies, including the Department of Corrections, the Department of Children and Families, Department of Mental Health and Addiction Services, and the Department of Social Services and Court Support Services Division, Organizational memberships include Alpha Kappa Alpha Sorority, Inc., Tau Xi Omega Chapter, Hamden, Connecticut, the National Association of Negro Business and Professional Women, Inc., Elm City Club, National Association of Black Social Workers, New Haven Chapter, and the National National Coalition of 100 Black Women, New Haven Metropolitan Chapter. I introduce to you Dr. Sharon Jones McCann.
Good evening, and thank you, Kai. Good evening, ladies. Thank you for joining us in our second of 4 series, and tonight's series is Pre-Screening and Managing Chronic Condition. First, I'd like to introduce our panels for this evening, and I'd like to start with Dr. Cynthia McCraven. She is a board-certified OBGYN. She graduated from Yale School of Medicine, did her residency training at Yale New Haven Hospital, and is a member of the American College of OBGYNs. Dr. McCraven has been in private practice for over 30 years in the greater New Haven area, specializing in general OBGYN, infertility, and minimally invasive surgery. Dr. McCraven currently sits on the advisory board of Women's Health Research at Yale, Board of Directors for Hartford Healthcare, Central Region, Board of Directors of Women's Health Connecticut, and the former assistant professor of OBGYN at the Franklin H. Netter MD Medical School at Quinnipiac University. Then we have Dr. Jamel Harp, and Dr. Harp is an MD, MBA, FACOG, is a graduate of Spelman College in the University of Connecticut School of Medicine. She completed her residency in OBGYN at Morehouse College of Medicine. Subsequently, she completed the fellowship in advanced GYN. Dr. Harp has a double board certification in OBGYN as well as female excuse me, I'm so nervous, female medicine and reconstructive surgery. Dr. Harp serves on the faculty of Morehouse School of Medicine and the VA Department of OBGYN. She has returned to her home state of Connecticut, where she has the privilege of serving as the principal physician for the state of Connecticut. And last but not least, we have Dr. Janice Nelson. Dr. Janice Nelson, DNP, APRN, BC-ANP. These ladies have a lot of initials behind their names. Currently works as the nursing director at UConn and the program director of the New England Sickle Cell Institute, Connecticut Bleeding Disorder Programs, and the outpatient behavioral health programs at UConn Health in Farmington, Connecticut. Dr. Janice Nelson earned her master's at Yale University in 2003 and her doctorate from UConn in 2017. She actively serves on both the local and national Sickle Cell Disease Association board. During her tenure on the national board, she has served on the program committee and helped to reorganize the structure of the nursing symposium while serving on the board. Ladies, these are our panelists for this evening. Thank you all. Good evening, ladies. I'd like to start this evening's questioning, actually our little talk with Dr. McRaven. How are you, Dr. McRaven? Can't hear you.
I'm well, thank you.
Thank you, good. Dr. McRaven, what should a woman do to make her pregnancy more safe for her and her baby if she has high blood pressure?
Well, the first thing that I would recommend is if she is even thinking about becoming pregnant, that she come into her primary care and get her blood pressure checked to see if it's in control at the time, and also to review her medications, because certain medications for hypertension are not safe for pregnancy. And she may have to be changed from her current regimen over to different types of high blood pressure medicines that can be used throughout the pregnancy. Additionally, it would be a good idea for her to have a home blood pressure monitor cuff. She may be able to get that at any of the pharmacies for $20 or $30, but she can also ask her physician to write a prescription. Many insurance companies will cover that blood pressure cuff if she has a diagnosis of hypertension. So those are the first two things that I would say.
Thank you. That sounds interesting. It's always hard for women to grab those blood pressure cuffs, and it would be great if all doctors' offices could offer that to the women to have these things done, especially women of color. Dr. Harp, why are there so many blood tests during pregnancies? What are they checking for?
Well, thank you. We're checking for conditions that can be treated early in pregnancy. A lot of times, what we want is for people to come in kind of preconception, so before they get pregnant, so we can check for some conditions. So let's say they're not. We check to see if someone's immune to varicella, which can cause chickenpox, and if someone's exposed to that during pregnancy, it can cause birth defects. So ideally, they will have received the vaccine before they get pregnant. The same thing with rubella, which is also a virus that's called the German measles. So we want people to receive those vaccines prior to pregnancy to reduce the risk of potential birth defects if they're exposed to someone that has those types of infections. But commonly what we do is we check for a blood count. So we want to make sure that somebody is not anemic, meaning having a low blood count. Sometimes, especially in the African American population, women that have a low blood count, it could be due to iron deficiency. It could be because they may have sickle cell disease or thalassemia, which we'll hear more about sickle cell disease with our other panelists. But things that we can treat early in pregnancy, that's what we're testing for. So checking the blood count, we can easily treat iron deficiency. We would give the person iron during pregnancy. We want to make sure that their blood is clotting normally. So that's something else that we can check for with the panel of tests that we do. We want to see if what someone's blood type is. What some people need to know is whether or not they're Rh positive or negative. So let's say someone is O negative. The negative part meaning that you don't have a certain protein on your red blood cell. The reason why that's important is because if the baby does have that protein, so let's say they're O positive and the mom is not, I hope this isn't getting into the weeds, but the reason why that's important is because mom's body can see that the baby's blood cells as being foreign, and it can create antibodies that end up attacking the baby's blood cells. So the reason why we check early in pregnancy is because we can give mom a medication that will prevent her from developing those antibodies or proteins that can attack her baby's blood cells. So that's why it's important to come early in pregnancy so that we can determine if things like that are present, so we can help prevent serious complications from happening. So those are a few blood tests that we perform, and I can talk about some later if we have additional time.
Thank you so much. Very interesting information. The O positive and negative, that's really something that a lot of us do not know about. So it's great to hear that information. Dr. Nelson, Dr. Hart mentioned sickle cell. So for a woman with sickle cell, let's say she has sickle cell and she wants to have a baby. Where does she go? How do we start? What happens?
So that's a great question. Thank you. Generally, like Dr. Harp said, we want to make sure that a person is as healthy as possible. So we do want to do lab tests. We want to check, especially in someone who has sickle cell disease, because they already have chronic anemia. So we want to help to make sure that their blood levels are safe to carry a pregnancy full term. So we want to check to see what their anemic status is. We want to also check the status of the father. We want to see what the baby's father has, whether or not they have sickle cell disease and or sickle cell trait, because those are different implications for an individual who has sickle cell disease who's talking about pregnancy. So if it's available to them and they're not already pregnant, we want to offer them gene counseling. So genetic counseling is available with most hospitals who have maternity services. So we have genetic counseling services that we can offer to them at UConn. Yale does as well. And so if they're not pregnant, if it's somebody who's planning, which typically people come to us, they're already pregnant. So we're starting behind the 8 ball. But if they come to us early enough, we want to send them to have genetic counseling so they can know what their options are, what the father of the baby status is, because the status of the baby's father is implicates whether or not they may have disease and or sickle cell trait. Along with the mother. So there's a lot of genetic information that can be discussed prior to them becoming pregnant so they can, again, know what their options are for pregnancy, what the possible outcomes may be.
Wow, thank you. That is a lot of things, and it's also involving the father, which is an awesome thing. Dr. McCraven, I have a good question. We know that as African-American women, we are sometimes overweight. We carry a little weight with us. Why does carrying extra weight, the increase in the BMI, make such a difference when you are pregnant? It makes it so difficult what happens.
Well, we don't have we don't own that completely all by ourselves. There's a lot of women out there who carry some extra weight. So we're going to spread that around to all. But I think that we can become a little more comfortable with that weight and thinking that it's not such a bad thing. But for pregnancy, it can be. Number one, it can affect your ability to become pregnant. You could have the development of polycystic ovarian syndrome, which is where you don't ovulate regularly. So it can affect that. So that is another reason that women might need to come in when they're thinking about getting pregnant and see if we have to help them with tracking their cycles. The other thing with the overweight, well, we call it BMI, and following our BMI, is that the high risk society, the Society of Maternal Fetal Medicine, has stated that women who are at a BMI of 35 or greater, they fall in a high risk category where we have to do more testing on their baby prenatally, because they actually can become growth restricted, or it's called growth insufficiency in some areas. And that means, although you may be carrying extra weight, your baby could be very small and not growing appropriately inside, and actually could end up with a stillbirth. So that is one thing that people are not necessarily thinking about. So you may find that if you've had multiple pregnancies, there are things that are being done differently now in a subsequent pregnancy than what you had before, even though you might have been the same weight, because we've identified through the studies that these babies are at risk in the situation where you are carrying that weight that puts you in that BMI category greater than 35. Additionally, it puts you at risk for developing hypertension during the pregnancy, as well as it turning into preeclampsia. It puts you at risk for developing pregnancy related diabetes, and that can cause problems with the growth of the baby. And actually, that weight can cause you to be at risk for having a cesarean delivery, and all of the types of surgeries that are done in patients who are carrying extra weight. We have problems with healing. So your incision may not heal quickly. It may open during the healing process. It may be a very difficult entry into the abdomen to get to the baby. It all depends on where that weight is being carried. Some people carry it in their hips. Some it's right on the abdomen where we want to operate.
Well, thank you. You never think that all of this, that extra few pounds makes such a great big difference in the birth of your child. And it's so strongly involved in being healthy to deliver that baby. Question for, let's go to Dr. Hart. We mentioned tests and blood, but we never talked about why are pregnant women tested for sexually transmitted diseases, infections and diseases?
Thank you for that. And you know, the main reason is because a lot of sexually transmitted infections are treatable. So we can treat a number of them. We can also help reduce the risk of transmission to the baby if we know early enough. So it's important when women come for their first prenatal care visit, which hopefully is early in the first trimester, in the first 14 weeks, that we test for sexually transmitted infections. One thing that I do want people to know is that HIV infection, in 2021, the CDC came out stating that 62% of all children that are less than 13 that have HIV are African American children. And so, you know, which makes me feel like, you know, a lot of that has to do with how well we're screening and treating women during the pregnancy. So what can happen with HIV infection is if a woman comes and she's not received any treatment whatsoever, the risk of that baby having or HIV is about 25%. But if we treat early enough and a patient comes early enough, then we can reduce that risk of the baby having HIV or reduce the transmission rate to less than 2%, which, you know, which is good for baby. And then hopefully decrease the risk of mom having a C-section, because if the load of the virus of HIV is too high, then we're going to recommend a C-section to reduce the transmission rate. Syphilis is also something that's really increasing in the community. I know that's not something that a lot of people hear that often, but there's been an astronomical rise of syphilis, which is too bad, and including congenital syphilis. What can happen with syphilis into babies that are exposed to that infection is that there can be bone disorders, there can be miscarriages, there can be stillbirth. Babies can be born blind or deaf, or they can become blind or deaf within 3 months of delivery. So, and there's a higher risk of neonatal death, but it's easily treatable. You know, we give people, if we find out that someone has syphilis, we give them an injection, a shot of penicillin, and then that will treat it. So ideally, people will come in early. We'll treat them for syphilis. Gonorrhea and chlamydia are tests that we also check for. They both can increase the risk of miscarriage. They can increase the risk of blindness if baby goes through the canal, the vaginal canal, without mom being treated. So also easily treatable infections. And then hepatitis B and hepatitis C are also infections that we test for. Neither one, we don't treat either one during pregnancy. Hepatitis C, if we know ahead of time, we can treat prior to pregnancy. Afterwards, after the mom delivers, we can treat for hepatitis C. But the importance of knowing is that if mom needs special care during the pregnancy, we're able to provide that. And then for hepatitis B, the baby can be treated immediately after delivery with the hepatitis B vaccine. So it's just extremely important that people come in, because a lot of the complications that could arise can either be prevented or we can mitigate those. I did just also want to mention that we do test the urine for a number of reasons. We check to see if there's any protein, which could mean that there could be a kidney problem. It could be that mom might be developing preeclampsia, which typically happens later in the pregnancy. We check for infection of the urine, and we check for glucose to see if mom might be at risk for developing diabetes. And And then I also wanted to mention, because I failed to mention earlier, that we do check for diabetes in pregnancy, typically closer to like the 6th to 7th month of pregnancy, we check for diabetes as well. So hopefully that answers the question.
I mean, it was fantastic, very informational, and knowing that how some children have to be delivered because of moms not getting medical attention early enough to prevent something that is preventable and giving the baby a safe passage into this world.
If I can just, sorry, I'm sorry. If I can also just say, it's important also to know if mom has herpes or a history of herpes. And the reason for that, I think a lot of people really freak out when they find out they have herpes, and it's, you know, I know it sounds like it's bad to people, but I mean, it's the only thing that, the only time it can really truly harm someone is during delivery. So, you know, the reason we need to know ahead of time so that we know what to look out for, because people don't necessarily test patients for herpes or for whether or not they've had it in the past. We really need to know, because around 36 weeks of pregnancy, we put people on, you know, a medication like acyclovir or valacyclovir to try to prevent them from having an outbreak of herpes. And the reason why we do that is because if there is an outbreak like on the vagina or in the like on the lips of the vagina or on the cervix or anywhere like that, the woman cannot deliver vaginally because we don't want baby to have herpes. So the mom would have to have a C-section. So the reason why we put people on medication is to prevent them from having an outbreak so that we can prevent them from having a C-section. So I just wanted to mention that also.
Thank you for mentioning. It sounds like things that I heard years ago. I'm a little bit older than you all. Years ago, it seems like it's all back in action. You know, I mean, we heard of herpes when I was in high school, but then you didn't hear of it. Now I'm hearing of it again tonight, like it's never, my thinking never went away. Okay, Dr. Nelson. For women with sickle cell disease and pregnant, there's a lot of pain associated with sickle cell. What can she or should she take for pain medication while she's pregnant?
That's a great question. Oftentimes, people are concerned about opioid use in not just pregnancy, but in general. But in an individual with sickle cell disease, the only thing we have for pain is opioid pain medication. So if they are taking opioid pain medication on a somewhat consistent basis, then it's something that they should continue during the time of their pregnancy. And so the OB team needs to be made aware, the maternal fetal medicine team needs to be aware, along with whoever the sickle cell provider is, so that they can monitor the use. And the reason being is that you want the baby to be in as a normal or safe environment as possible. So if the woman is struggling with pain and not taking her pain medicine, she's creating a hostile environment and trying to grow a baby with having issues with anemia, meaning have low blood counts, may need to have blood transfusions to support their pregnancy. So it's really important to try to minimize as many outside influences on the pregnancy as possible. And so taking regularly scheduled pain medication, if it's needed, is something that should be continued during their pregnancy. When someone is pregnant is not the time to now say, oh, we're going to withhold opioids or pain medications. They need to be supported through their pregnancy. So if they have pain that's not taken care of with their oral medications, they need to then come into either the infusion center or emergency department and be given medication along with IV hydration to, again, ensure that their pain is as well controlled as possible, because you want to eliminate physiological stressors, and having pain is a physiological stressor to a pregnancy. So you want to minimize as many outside stressors to have as near normal pregnancy as possible.
Thank you. Thank you. This is all so interesting. And I'm going back and forth, and I have all these wonderful questions. I have one for Dr. McCraven. When Dr. Harp talked about diabetes, if a woman has diabetes before pregnancy or develops it during pregnancy, what impact or risk does that have on the safety of that pregnancy? You're on mute.
Thank you, thank you. If the mother has diabetes before she becomes pregnant, it would be recommended to make sure that her blood sugars are in good control before she becomes pregnant. Number one, having uncontrolled blood sugars is not a good idea for her. It could cause her to faint or not feel well. She could go and potentially become unconscious, depending on whether she's type 1 or type 2 diabetes, if her blood sugar is too high or too low. But additionally, when the blood sugars are not in control, you can have birth defects. And one that I've only seen one in my career, but it is where you have fused lower extremities. And that can happen by having just too high of a sugar. And it was called the mermaid legs, but that is a real thing, or that the bottom of the baby doesn't develop fully. So it would be a good idea to make sure that your blood sugars are in good control. If you have the blood sugars under good control, there can still be risk for miscarriage. Okay. So you want to go in and be seen early. And in terms of safety for the pregnancy and safety for the mom, it's important that we have good control, because it can cause the baby to develop much larger than we would like to see it. And we worry when someone comes in and tells us that they've had an 8-pound baby prior. People think that a big baby is a good thing. Not always. And when you've had a baby that's 8 pounds or larger, we are thinking that potentially you had undiagnosed diabetes in that pregnancy. So again, as I talked about before, you could have a higher risk of stillbirth, okay? A higher risk that you may have to be delivered by cesarean. If the baby does start to come down the birth canal and it has put on too much weight because the blood is sugar rich, the shoulders develop like a football player, and the baby's head may come out, but the shoulders will not come out. And we could have a baby that experiences what's known as a shoulder dystocia, where it is actually stuck in the birth canal and can undergo a very traumatic delivery and potentially have injury to the arms where they are not functional because of nerve damage, things of that sort. So we would like everyone to really think of diabetes as something that you can control, and you have a good amount of input on how that's going to go in your pregnancy. You just have to be disciplined, and we do recommend exercise to help you with that.
Oh, thank you. You never think of all these complications that could happen from not being healthy or not being prepared. So we got to continue to make sure that we prepare our folks for this information, giving it out. Dr. Nelson, help me to understand, can the baby of two individuals with sickle cell trait be born without sickle cell disease?
So that's a great question, and we get it all the time. So in individuals who have sickle cell trait, if both parents have sickle cell trait, the chances that they have a child with normal hemoglobin is 25%. So in an individual who has sickle cell disease, along with an individual who has sickle cell trait, then their percentages for having a child with normal hemoglobin diminishes. So when you think of what the baby's going to get, each parent gives them 50% of their gene. So you get one set of genes from mom, one set of genes from dad. And so depending on what that combination is, determines whether or not the child has sickle cell trait or the child has sickle cell disease. And so that's why genetic counseling is important, and it's important to know what the status of the mother is and what the status of the father is. So if you have individuals who have sickle cell disease, and there's a lot of different alphabets when it comes to sickle cell disease. So depending on if someone has, say, homogeneous sickle cell disease, SS, and mother and father both have SS, all they can pass on is S's. So all of their children will have sickle cell SS disease. But if you have a parent who has sickle cell SC disease and someone who has SS disease, then you have a chance to have a child who has SS disease, you have a child who could have SC disease. So when you mix different things with sickle, you form some kind of sickle cell disease, and there's a whole alphabet soup. So you can have sickle hemoglobin SC disease, sickle beta thalassemia plus, sickle beta thalassemia 0. You can have sickle cell disease D, sickle cell disease E, there's ORF. So it's important to know if you have one individual who has sickle cell trait, if you mix sickle cell trait with another form abnormal hemoglobin, you form some type of abnormal sickle cell disease. So it's really important to understand that depending on what that gene pool is that you have to pull from, because you're going to get half of your genes from your mom, half of your genes from your dad, and that determines whether or not your child has disease or whether or not they have trait. So if you have two individuals who have, say, SC disease, you can have a child that has CC disease because mom has passed on a C, dad has passed on a C. That's not sickle cell disease. That's a different type of anemia. So it's important to get an understanding of what that is if you yourself have trait or it runs in your family, or if someone in your family has sickle cell disease and you are now talking about having children. It's important to plan this out versus having something happening and then trying to figure out, okay, will my child have SC disease, SS disease, SE disease, no disease? Because if you have two people who have trait, you can also have a child who has no trait. They have normal hemoglobin. So it becomes kind of like a throw of the dice. You know, when you have a dice, you have 6 sides to a dice. When you have a genetic disorder, there's only 4 sides. So you only have several options to get something when you're talking about having children. And so that's why it's important to get all of these pre-screening things done, know what your labs are, know what your hemoglobin status is, know what your BMI is, so that when you go into pregnancy, you go in as healthy as possible so that your outcome is a healthy baby.
Thank you. Wow. That's a lot of alphabets. It's a lot.
It is. It is.
So Dr. Hart, I'm going to say the last question for you. And this one is really a mind bug. Ready? Why do OBs ask so many personal questions?
Well, you know, there's a lot of information that we need to know in order to adequately take care of patients. So, you know, one thing that I failed to mention, and I will go back to that, is genetic testing, because, you know, if you're interested in knowing if your baby has a genetic disorder, that's something that you can be tested for during pregnancy. Not everyone has to do it, but if it would change what you would do regarding the pregnancy, then it's something that you can be tested for, screened for, different types of chromosome disorders or gene disorders. So I just wanted to mention that. If people have a question about that, we can talk about that later. But to answer your question, past medical history is extremely important. Dr. McRaven mentioned people having chronic hypertension. It helps us as OBs to know that history, because if they do have a history of chronic hypertension, we would put them on like a low dose aspirin when they're 12 weeks pregnant to help reduce the risk of them developing preeclampsia. So that's just an example. We would need to know what surgeries they've had in the past, because if they've had a lot of surgeries in the past or a lot of scar tissues, and that puts them at risk for that scar maybe opening up earlier in the pregnancy. So they may need to be delivered a little bit earlier, especially if they've had a number of C-sections, because when you have an incision on your uterus, especially if that incision is up and down on the uterus, then that area, when a person starts to contract, it puts a lot of pressure on it, and it makes it a little bit weaker. So we normally would deliver somebody a little bit earlier, depending on the type of incision that was on their uterus. So that's important to know. Social history is important. So even the social part of the social history is very important. Do they live in an environment that's healthy for their mental health? Is it going to be healthy for a baby when baby goes there, and safe for baby? Whether or not they have a history of alcohol use, or alcohol abuse, or drug disorders, because there's a lot of help that women can get. I think a lot of times people feel like they can't or don't want to communicate with their providers about issues regarding drug use and abuse, but our job is to help take care of you. And that includes and encompasses everything that you might be embarrassed about. We just want to help you have a safe and healthy pregnancy. So the way that we can do that is by knowing everything that could potentially cause harm to you or the baby. And so just informing us of those things that you might be even a little bit embarrassed about is helpful, so we can help you get the support that you need, and the medications that you need. So for instance, if someone has an opioid use disorder, then maybe they need to start methadone. That might be helpful for them during their pregnancy. So that's why we ask a lot of questions, so we can help people have a healthy pregnancy. And also mental health questions are extremely important. I think a lot of people want to kind of act as if they don't have a history of depression or whatever the health issue is. And our, kind of like the college that governs us, the American College of Obstetrics and Gynecology, tells us it's safer for moms, safer for babies, for moms to stay on their antidepressant, so long as it's not something that is, that can cause any birth defects. And most of them do not. Most of them are safe in pregnancy. It's safer for mom to stay on them than not to during the pregnancy. It's safer for her during it. It's safer postpartum. So we just want to make sure that moms and babies receive the support they need. So I know that was long-winded, but
It's great. It was great because, sometimes you go and you feel like they're just sometimes want to know too much, but it's never too much. Now that we hear that, it's never too much. I would like to thank my panelists for such great answers. You ladies were so informative. I hope those who were listening in on this webinar has gotten some great information. I hope they have great questions. And I'm going to turn this now over to Ms. Perry.
Sharon,
Yes, ma'am.
is it possible for me to just add something on to Dr. Harp's comment about the depression?
Sure, you can have two and two.
Okay. Because of the maternal mortality crisis, the Black maternal mortality crisis, we are trying to make an impact there. And the mortality for Black women, it is counted all the way up to 1 year post-delivery. And the majority of deaths that occur in that time frame are related to mental health issues. So in terms of what Dr. Harp is saying and how many questions we ask and how often we want to see you back, if you have started the medicine, it is because it's been identified that that is a very vulnerable time period. And thankfully in Connecticut, we've had a Medicaid expansion that will cover us, cover the patients all the way to a full year for care post-delivery. That's it.
A great 2 and 2. That was very needed. Thank you so much, Dr. McCraven. All right, I'm going to turn it over for our Q&A. Ms. Perry.
Thank you, Dr. Sharon, and thank you to our guest panel of experts for such a powerful and informative session. I'm going to take it to the Q&A to see if there's any questions there. And if you haven't had time to do so, please use this opportunity to put your questions into the Q&A option on the bottom. While we wait for questions, although we're on a board together, there were some things that came up for me that I had a question about, and this question was specific to Dr. Jamila Harp. You spoke about a number of blood tests that women who are contemplating pregnancy or want to have a baby that they should get to determine, like kind of iron deficiency, blood types. Are the suggested tests that you recommended, are they a part of a routine women's exam where they would otherwise get this information, or is it something specific that they need to ask for?
Typically, so if people are considering getting pregnant, then I think just I would go to an OB who, so that they can do preconception counseling. And then I would ask for, it depends if you want to know about your carrier status. So the tests that we mentioned are important, like the CBC, whether or not you're immune to certain viruses like rubella, varicella, things like that, so that people can, prior to pregnancy, get vaccinated. But, there are other things that are also important. So if you're interested in doing carrier screening, which is genetic testing that can be done by both mom, or the future mom, and also the future dad. And that can let someone know if they carry certain genes. So if they carry a gene for cystic fibrosis or for spinal muscular atrophy, those are things that we, if that would change how you would, what decision you would make going forward if you were to get pregnant, then I would recommend having that testing done. Sometimes just general health lab tests, like, is your cholesterol normal? I think that's important. People that have had a history of high blood pressure or preeclampsia in the past, we normally do what's called baseline blood tests. So we check to see how their kidneys are functioning. We check to see how their liver is functioning. And then we do a baseline EKG. We do that in the very beginning of pregnancy based off of the history of the mom or soon-to-be mom.
Thank you for answering that question. There are some other questions in the chat, so I'll start with the beginning. I'll start with one. What is a healthy weight to gain while maintaining a healthy lifestyle that doesn't make one at risk for diabetes during pregnancy?
Well, it depends on what weight you where you are, what your weight is at the time that you are contemplating getting pregnant. If you are in what is considered the average weight, then 20 to 30 pounds maximum. Okay. And it is a slow weight gain. In the first 20 weeks, we only expect you to gain between 5 and 8 pounds. So if you've put on a lot of weight at the beginning, you're going to continue to put on a lot of weight at the end. And so you can just about judge if someone's gained like 25 pounds by 20 weeks of pregnancy, they're going to probably gain at least 25 pounds. So they're going to be on 50-pound weight gain total pregnancy. So people are worried at first that they're not gaining weight, but we don't expect you to gain a lot of weight at first. If you come in weighing more and you're above the weight curve, so to speak, you may only need to gain 10 or 15 pounds in the pregnancy. And we will tell you that as you come in and you get your intake visit and we assess where you are and where you're starting from. And we really would like it to be 1 or 2 pounds at a time. When someone comes in having a 10-pound weight gain within, a 2-week period of time, we've got to look at other things. Potentially, they may be developing preeclampsia, and that may be a lot of water weight that they're gaining. Also, if you have a family history of preeclampsia, your mom or sister or someone, even if this is your first pregnancy, we need to know that because your risk of developing preeclampsia is higher if there's a family history of that. And we use that to also decide whether we're going to put you on an aspirin or what kind of screening we're going to do during your pregnancy, even though you have not had it. So do you have anything different to add, Jamil, in terms of the weight issue?
The only thing that I would say is a lot of people think that they have to eat for 2. You do not have to do that. That's not what you really only need. An extra 300 calories a day, or an extra, and then maybe in the 3rd trimester, extra 400 calories. That's really kind of just like a snack. So I think that's a misconception. I think that people think that they're eating for 2. And then when you do eat, you need to do your best to try to choose healthy snacks, which I realize, depending on where you live, is not the easiest thing to do.
We may have to resist some of those cravings that come out.
Well, thank you, Dr. McRaven and Dr. Harp. Our next question is, can you test for genetic disorders before you conceive?
So-
Go ahead.
No, go ahead. Sorry.
Well, you can test to see if you're a carrier for a certain genetic disorder, or if you yourself have already been diagnosed for that. For example, if you are a patient that has cystic fibrosis, we know you have that genetic disorder. But if you don't show that you are affected with cystic fibrosis, you can be tested to see that you are a carrier. And it's pretty much like sickle cell. Both parents have to be carriers in order for the baby to develop cystic fibrosis. And so, yes, there's a whole panel, I think 200 and something things that we can test for. We will look at your family background and maybe say, we recommend this panel of tests, not this panel of tests. And in terms of questions, we do need to know how people are related or not related, because those things can cause problems.
Thank you, Dr. McRaven. Any of the other panelists want to expand on that, or should I move on to the next question?
I think since we're talking about genetic testing, I did just want to mention, so testing for the baby can be done, or to see if the baby has a genetic disorder, can be done in the 1st trimester, 2nd trimester. We normally also do that along with ultrasound. So we typically have patients get an ultrasound around 5 months of pregnancy, because the baby's large enough to see if there's any kind of abnormalities or defects. So they normally look at the main structures of baby, like baby's brain, baby's spine, baby's heart, baby's belly, baby's arms, legs, and digits. So that's done along with the blood tests. I think a lot of people like now is the test where they want to know the sex of the baby. That's called cell-free DNA testing, or NIPT, like non-invasive prenatal testing. And the way that's done is by checking mom's blood. We can do it when people are over 10 weeks pregnant, and it can be done during any trimester. So let's say, for instance, for whatever reason, mom at around 8 months decides, you know what, I want to have that testing done. Maybe she didn't want it done prior. It can tell us, that's not a good example, but essentially what the testing can tell us is it can tell us if there's a chromosome disorder like Down syndrome. It can tell us, and it can also tell us the sex of the baby. Some people like doing that because they can do it earlier in pregnancy, and then they know if they're having a boy or a girl. But the other benefit is knowing if there's some chromosome disorder present.
Thank you, Dr. Hart.
So I was just going to add, for individuals who have sickle cell disease, sometimes they're offered to have amniocentesis, but those are more invasive tests, and there are risks with invasive tests. And so, as Dr. Harp has said, if they're not going to change the outcome of their pregnancy, meaning that they're not going to do anything differently, then they probably won't take the risk to have amniocentesis. But if they're concerned that there may be some anomaly or there's something wrong with the baby, then they may opt to have an amniocentesis. I can't get my tongue to work with my brain, or chorionic villus sampling, which could be done even sooner. But again, these are invasive tests that have risks with them. And in the patients that I've been taking care of in the last 20 years, no one has ever decided to use a test to change the outcome of their pregnancy. Just wanted to put that out there.
Thank you, Janice. The next question is, what resources would you recommend to check if medications are safe during pregnancy outside of an OB office?
So there are a lot of resources that people can look to see so there are letters that are assigned to many medications. And if something is considered to be harmful to a baby, they can easily find that information on in a medical text or Google, because that's information that's readily available. You can ask your pharmacist if they can share that information with you as well. That's finding out whether or not medications are harmful to babies is something that's relatively easy to find out without having a discussion with your provider. But you should have a discussion with your provider if you're thinking that it's going to impact your care, or you need to change your medicine or something like that. You shouldn't arbitrarily stop taking medications without having a discussion with your provider, even though you found out that the medicine is safe or it's considered possibly not safe. They should have that discussion before removing those medications if it's something that they're prescribed.
Thank you for that answer. So that is all the time that we have for our questions. I do see that there are a couple of questions left, but I encourage our panelists to type responses if they're able to. Dr. McCraven, I see that you're doing that. We appreciate it. Thank you so much. Continue to add your questions, and we will answer them if we have the opportunity to. So thank you to our moderator and our guest panel of experts for such a powerful and informative session. You will see an option display to partake in your second poll for the evening, and I will allow you some time to complete that. I was remiss in giving you enough time earlier, so I will make sure that I give you enough time this evening to complete your second poll. Okay, hopefully that gave everyone enough time. Thank you for your participation. And if you answer both poll questions, you will be entered into a drawing for a $75 gift card. And I'd like to announce that our last winner from our first webinar series, the winner was first name Harriet. She was our poll winner from the last session. If you're interested in learning about any future sessions that'll be occurring or to learn more about the Black Maternal Health Project, we encourage you to scan the QR code that is on your screen. We look forward to seeing you on January 8th for our next series, The Importance of Mental Health. Also, we will have an upcoming summit on April 12th at Southern Connecticut State University. Please follow our social media pages for more details. We thank you for joining and have a great evening.